I'll be with you in just a sec. Well, it's about to get real hot in there, which is appropriate because we're getting into piping hot anterior segment topics in this session. First up is Managing Presbyopia in My Practice, No Problem, by Dr. Sheetal Brar from India. Second, Cataract Surgery, six Tips for Unusual Situations by Dr. George Beiko from Canada. Number 3, we all deserve second chances, modular and multi-component IOLs by Dr. Harvey Uy of the Philippines. And fourth, the drug compliance conundrum, a case for glaucoma diaries by Dr. Sahil Thakur of India. Well, it's getting hot in here and there's no chance of cooling down. Get as comfortable as you can and let's go for it.
Hello friends, I am Dr. Sheetal Brar, a senior consultant working at Anterior Eye Hospital, Bangalore, and I'm here to share my experience with treating presbyopia patients in my practice. I'm very glad to be here at the CP EXPO, and I'm very grateful to my friends Matt and Ruchi for inviting me to this wonderful conference and giving me this amazing opportunity. So let's move on to the talk. Why do not I find a problem to treat patients of presbyopia in my practice? So I'll be just sharing my experience about treating presbyopia and how we have come a long way from using techniques like conductive keratoplasty, which are almost obsolete now, to practicing techniques like press beyond and smile monovision, which are very advanced techniques currently. So if you look at the profile of the various presbyopic treatments which are available to us today in this world, you can see that we have an array of options to treat presbyopic patients. We have corneal inlays, or CK, which is of course not being used now. We have various types of LASIK procedures, starting from monovision LASIK, multifocal LASIK, which is PresbyMax. Then we have the laser blended vision, or Press Beyond, from Carl Zeiss Meditech. Then we have lens-based options as well, such as a refractive lensectomy with different types of multifocal and accommodative lenses. And the new kid on the block is presbyopic phakic IOLs, which is still an evolving concept. We must always understand that every presbyopic treatment is essentially a compromise. You can have a reduction of contrast sensitivity after the procedure. There is a chance of drop in distant visual acuity, which must be explained to the patients. Good light conditions are very important, especially for reading. And patients invariably have to adjust to the new kind of vision. They need to find a new near point at a specific distance from the eye at which they are most comfortable. And they need some time to adapt to this new situation. The aim of any kind of presbyopic surgery essentially is to give you maximum independence from glasses with the least compromise. So I must say that we are simply reducing the dependence of the patient on reading glasses, but we may not be able to completely eliminate it. So patients must know that they may still require temporary glasses or enhancements in the future. Now, going back to our experience, which we started in 2002 in treating our presbyopic patients, we started with CK, or conductive keratoplasty. We did this procedure for only 1 year and we found a lot of side effects with this. I'll be talking about it later. Then we shifted to PresbyMax LASIK, which is still being practiced in various parts of the world. This is available with Schwind Eye-Tech solutions. And we used this procedure for a fairly good length of time, almost 5 years. And then now we have completely shifted to press-beyond LASIK from 2015 onwards. This is our preferred presbyopic treatment available in our practice and has been highly successful. And now, since 2017, we are also exploring the possibility of using smile monovision also as one of the options. So if you look at the profile of refractive surgery in Netradhama, you can see that press-beyond is almost 10% of all the surgeries, and smile monovision forms 2%. So it just started with smile monovision, and this looks quite promising as of now. So conductive keratoplasty essentially was a thermoplasty technique which used radiofrequency energy to heat and reshape the cornea. We just performed about 28 patients, and we found that the near vision in the initial phase, say like first 1 month or 2 months, was good. It was not bad. 90% of patients achieved 6/9 N6 vision or better in the initial post-op period. However, the procedure showed a very high rate of regression, and almost complete reversal of the effect was seen by 1 year or about 15 months in most of the cases. So this was the main reason why we had to give up on conductive keratoplasty. Experience with Presby Max was better. It was better than CK, and we did this procedure for almost 5 years. This sophisticated software is available with Schwind Amaris laser, and this allows us to simultaneously treat emmetropia, myopia, hyperopia, as well as astigmatism along with the presbyopia. The principle essentially is creating multifocal corneas wherein you have dedicated zones for distance, near, also with the transition zones. The main problem with this procedure was a significant loss of distance vision, which was experienced by most of the patients. So 45% patients had loss of 1 or more lines of distance vision at 15 days follow-up, which is very significant. And 2 eyes had a drop of more than 2 lines. And this is the main reason why we had to stop using this procedure, because the patients were not very happy with the distance vision, and also the quality of vision was not as great because the induced aberrations were very high. Press-beyond LBV. This is the most successful procedure in our practice, currently available with Carl Zeiss Meditech. And this works basically on 2 principles. The first principle is increased depth of focus, which is achieved by controlled induction of spherical aberrations. And the second principle is using a micromonovision protocol, wherein the dominant eye is targeted for emmetropia and the non-dominant eye is targeted for myopia of almost 1.5 diopters. The software uses nonlinear aspheric ablation profiles, which incorporate a pre-compensation factor to modify the spherical aberrations which are going to be induced with the procedure. And the post-operative spherical aberrations achieved with this procedure do fall in a range which gives us an increased depth of field, which is required for good near reading, without compromising on the contrast sensitivity and quality of vision. So all this is being planned by the software itself. Now, traditional monovision has some challenges. You can have blur intermediate distance. Anisometropia may not be tolerated by most of the patients. The distance vision can be poor in the near eye. There can be loss of binocular distance vision and loss of stereo acuity, which can be unrecoverable. So press-beyond laser vision, blended vision, improves on most of these challenges. So it was found in various studies that the current possible depth of field increase is only possible to up to 1.5 diopters. So essentially in press-beyond, what is happening is that we are increasing the depth of the focus of the dominant eye, bringing it closer towards the intermediate range by 1.5 diopters. And in the non-dominant eye, we are increasing the depth further away to almost again about 1.5 diopters, so that within the intermediate range, there is a blend zone. The patient's intermediate vision is very good compared to a normal LASIK monovision, wherein you want to do a monovision with 1.5 in the non-dominant eye and distance vision in the other eye, 0 in the other eye, what will happen is that in the intermediate vision, the distance, the vision will be very bad. So there will be abrupt blurriness, zone of blurriness. Whereas here, because the depth of focus of each eye is increased, so the distance eye comes closer, the near eye goes further. So in the intermediate range, you have a nice blend zone, which gives you a good intermediate vision, which is a huge advantage over LASIK monovision. Also, if you see the simulation of the non-dominant eye here, the vision at 7 mm pupil is very blurred. When some amount of spherical aberrations are being added, the image improves a bit. And if you reduce the pupil size further, which invariably happens with the accommodation, the image improves further. And when both the factors come together and the image goes through a central neuronal processing, it is perceived as a very clear image in the brain. Also, with the press-beyond laser, it is the summation, which is helping the patient to see well, compared to suppression, which is which the patient experiences in traditional monovision. Due to these factors, the tolerance of press-beyond monovision is much higher, almost about 97%, compared to LASIK monovision, which is only about 67%. Now, patient selection for press-beyond LASIK is very important. The patient should be suitable for LASIK from all angles. Age must be 44 and above, or a patient should already have a presbyopia, which is set in. And the distance vision should not be poorer than 20/25. Patient should have a tolerance of at least 0.75 diopters and a quick suppression and fusion, and also a motivated patient. The step-by-step evaluation involves verification of refraction, functional age, eye dominance, micro monovision tolerance assessment, suppression and fusion evaluation, and planning with the CRS master. We recently published our 1-year outcomes with press-beyond in JRS in last year, and what we found was that in the myopic patients, 86.8% patients saw 20/20 and J2, whereas in hyperopic patients, 74% saw 20/20 and J2. Safety was also a bit better in myopic groups, where 5% eyes lost 1 line, whereas in hyperopia groups, 9% eyes lost 1 line. Change in corneal HOA and depth of focus increase was more in hyperopia group compared to myopia. Of course, you can understand the reason why, because you are doing more correction in the hyperopia group. You want to make the non-dominant eye myopic, so you have to do more correction. So definitely more amount of aberrations will be increased. And the procedure did give us a functional range of up to about 2.5 diopters without a significant drop of contrast sensitivity. There were only 2 eyes in the hyperopia group which underwent early enhancement at 3 months. Patient satisfaction scores were slightly better in the myopia group for near vision at 1 year. So SMILE monovision indications could be any myopic, presbyopic patient. Patients who already have some amount of dry eye or who are contact lens users do not want to undergo LASIK. Patients who are contact sports players, and also older patients who desire a flapless correction. Initial experience has been very encouraging. 36 eyes of 18 patients treated. Mean age was 46 years. All patients were suitable for SMILE. Dominant eye was targeted at emetropia. Non-dominant eye was made myopic by -1 to 1.75 diopters, depending on the tolerance. 84% eyes saw 6/6 or better, and 94% eyes saw 94% eyes shows N6 or better. The fine stereopsis showed that the stereopsis was actually not lost at the post-operative. Uncorrected stereopsis was not significantly worse compared to the pre-corrected. Contrast sensitivity scores also did not show any significant difference. Also, there was a mild drop in the contrast. So initial experience shows that it is a good technique. It provided us satisfactory visual outcomes for distance, intermediate, and near. And there was no loss of corrected stereopsis. To conclude, press-beyond laser blended vision has stood the test of time. It provides us excellent safety, efficacy, and stability. which we've already shown in our population and published our results as well. Smile monovision, we are still exploring. We have a limited experience, but we find it as a valid option to manage presbyopia patients in select population. Thank you so much for your kind attention.
Thanks, Dr. Brar. I always admire your work in ophthalmology and on social media. What a maven. All right, next up is Dr. George Beiko. We're here with cataract surgery and 6 tips for unusual situations. George?
I would like to thank the organizers of the Cake and Pie Expo for inviting me to be part of the program. Today, I'd like to share with you some of the tips that I have learned that make cataract surgery a little bit easier for me. These are my financial disclosures. None of them are relevant to this talk. The 6 items that I'd like to cover are minimizing the induced astigmatism created by 6mm corneal incisions, managing corneal astigmatism in patients who have no access to toric IOLs, IOL calculations in patients with previous radiokeratotomy, extending the measurement range of manual keratometers, estimating keratometry in uncooperative patients, and the target refraction in keratoconus patients. Let's first look at minimizing induced astigmatism by 6mm corneal incisions. Let's look at some of the strategies that we can use when dealing with a 6mm corneal incision in order to minimize the amount of induced astigmatism. We can use a 6mm straight incision, and this has been shown to induce about a diopter of astigmatism. We can use a 6mm frown incision, and this also has been shown to induce about a diopter of astigmatism. Or we can use an inverted V incision, which also induces slightly less than a diopter of astigmatism. I would like to share with you another approach to this. This is an incision that I was made aware of by Dr. Lawrence Brierley, and it's called the L-shaped scleral pocket incision. First, we make a 3mm incision at the limbus. Then we extend that excision posteriorly for 3mm to create our L, and then we dissect into the cornea and sclera adjacent to this incision in order to create the 6mm internal incision. Sutures are rarely needed to close this incision as it is fairly self-sealing. The L-shaped scleral pocket incision can be used to manage an in-the-bag IOL dislocation. In this case, we're not sure whether it's a rigid or a foldable IOL, so we create the L-shaped incision after having initially placed an anterior chamber maintainer and also bringing the IOL bag complex into the anterior chamber. The L-shaped incision is created, and then a crescent blade is used to dissect into the cornea and sclera such that an internal opening of 6mm is created. The IOL bag complex can then be easily extracted through this incision, and the new lens can be introduced. This lens can be either a foldable lens or a rigid lens, as the incision would allow for the placement of a 6mm optic IOL into the eye. I've chosen to use interscleral haptic fixation, which I'm demonstrating here, in order to stabilize the lens once it's being placed into the eye. The L-shaped scleral pocket incision can be valuable when difficult situations are encountered. In this case, a dense nucleus with a posterior capsular rent was found at the time of surgery. The decision was made to convert from a phaco technique to a manual extraction. By converting the phaco incision to the L-shaped scleral pocket incision, it was possible to then extract the nucleus. It was also possible to introduce a larger instrument such as a lens loop into the eye to get the remaining fragment. An analysis has to be made of the incision by using corneal topography. When we look at the progression post-op of the corneal topography out to 6 months, we can see that there is no induction of corneal astigmatism. Here is another example in which topography was done out to 3 months, showing no induced corneal astigmatism from the L-shaped scleral pocket incision. And one more case followed out to 2 months, showing no induced corneal astigmatism. Professor Ota from Japan has analyzed this incision in a series of cases and has shown that there is no induced astigmatism. So the L-shaped scleral pocket incision is safe. It allows for stable anterior chamber control and wound management, and there's no significant induction of post-op astigmatism. The second item I would like to share with you is managing corneal astigmatism in patients who have no access to toric IOLs. Well, as you can see, corneal astigmatism is prevalent in our cataract population. 8% have over 2 diopters of corneal astigmatism, and another 30% have between 1 and 2 diopters. Not all patients are able to afford or have access to toric IOL, so in those cases, there are 2 strategies that I use. For the smaller amounts of corneal astigmatism, I'll use opposite clear corneal incisions. This is a nomogram developed by Al Masri from Egypt, showing us how much effect we can expect to get from these incisions. And here's a case in which we're going to use the incision, clear corneal incisions, to deal with about a diopter and a half of astigmatism. So using our 2.4 millimeter keratome, we create clear corneal opposite incisions, and here's another case. So it's a very simple technique and a very effective technique in dealing with low levels of astigmatism. In patients who have larger amounts of corneal astigmatism, we can use the conoid of Stern to our advantage. David Guyton has published this paper in which he has targeted a myopic spherical equivalent in order to deal with the corneal astigmatism. And these examples that I've shown you, the outcome refraction for 3 diopters of astigmatism would be minus 3.25 plus 3 for a spherical equivalent of minus 1.75. And using this approach, he has shown that patients will attain good near and distance vision greater than 20/50 without any spectacle correction. So again, a strategy that's very effective. Let's now look at IOL calculations in patients with previous radiokeratotomy. Okay, in the United States, approximately 250,000 RK procedures were done annually in the 1990s, and for us that creates a lot of headaches. RK is challenging because it flattens both the anterior and posterior corneal surfaces in a small central optical zone. Thus, using standard keratometry, we're not able to get reliable readings. In looking at the case, there are a number of strategies that you can use. You can average the 1, 2, 3, and 4 millimeter ring values of the atlas, and this will give you an effective K. Or you can use different devices to measure the K and then employ the flattest K as your average K for the calculations. Or, as it turns out, you can use the IOL Master. The IOL Master measures a smaller optical zone, and this effectively provides us with an average K that we can use in the ASCRS calculator, and then get access to the Holiday 1 formula, which has the Amberry double K method. For example, this patient who's had previous RK, topographically we can measure a central K of 35.5 diopters. However, if we use our IOL Master, we get a 35.17 diopter. So the average K is flatter and will be a better value to use. In terms of target refraction, it's been shown the IOL Power calculations can be improved if the flattest K is used and if myopia is targeted. So which formula do we use? In comparing the OCT formula to the true K formula, these were comparable to the double K Holiday 1 method on the ASCRS calculator. So either of these three formulas can be used. However, bear in mind that no formula was able to predict more than 80% of the eyes within 1 diopter of target refraction at 3 months post-op. So if we go back to our IOL calculator for eyes with prior RK on the ASCRS website, we place the central K value here, and then we place our K values from the IOL master in these slots. And you can see we have a number of values available to us in terms of IOL selection. So what is our targeted refraction? We should try and target myopia because the RK incisions swell and cause a hyperopic effect. So for 4-cut, target minus half a diopter. For 8-cut, minus 1 to 1.5 diopters. And for a 12-cut, minus 2 diopters. Intraoperative aberrometry is not helpful for us. We should do the non-dominant eye first in case we have some error, and then we can adjust this in our dominant eye. Toric IOLs are not helpful, so use monofocal IOLs. In terms of the patient education, we should advise the patient that the prescription will fluctuate from morning to afternoon as it did prior to surgery. The final refraction will take time to become established, usually about 4 weeks for 4-cut RK and 2 to 3 months for 8 or more cut RK. And the patient should be prepared for refractive surprises. So we should discuss with them possible IOL exchange or piggyback or BRK. So finally, the summary in how to deal with RK. I use the IOL master case and enter them into the ASCRS calculator. Target myopia based on the number of incisions. Allow 1 week per incision for refractive stability and be prepared for subsequent surgeries, and try and avoid patients with 50+ incisions. The next item that I'd like to look at is extending the measurement range of manual keratometers. Conventional manual keratometers measure the corneal curvature from 36 to 52 diopters. We can increase this range by taping trial lens spheres in front of the aperture. So by placing a plus 1.25 diopter sphere, we can extend the range up to 59 diopters, and by placing a minus 1 diopter sphere, we can extend the range down to 31 diopters. Our next item is estimating keratometry in uncooperative patients. Occasionally, we get patients who make it quite difficult for us to measure their K. So for these patients, I've come up with the following thought experiment. What do we know about Ks? Well, we know in the adult population, the average K is about 43.5 diopters, and that there's no correlation between the axial length and K. So we know that 1 diopter of K deviation equals 1 diopter of refractive deviation. When it comes to the axial length, the average axial length is 23.6 diopters. A-scan biometry, which is what we typically use in these uncooperative patients, measures about 0.2 millimeters less than immersion or optical biometry. And we know that the impact of axial length on refraction is about 3 diopters for every millimeter of error. So therefore, if we want to look at the effect of axial length on the refraction, we know that we can take the measured axial length, we can add the 2.28 millimeters because of using A-scan, and then subtract the average length for the population to get the deviation of the axial length from the population, and multiply this by -3 in order to get the refractive impact of this deviation. So putting this all together, in order to estimate the K, we can use the average K of the population, which is 43.5. We need the true refraction pre-cataract in order for this to work. So we subtract that from the 43.5, and then we add in the effect of the axial length, and this will give us an estimate of the K. In order to test this proposed formula, I looked at a series of patients in which I had the measured K. I used the axial length and the refraction to calculate the K, and in 75% of cases, the calculated Ks were within 2 diopters of the measured K. The highlighted ones were out of range. So this is a fairly effective formula that can be used to calculate Ks. The final item that I'd like to look at is target refraction in keratoconic patients. Thanks to Doug Koch, we have this study that has shown us that the keratoconus induces steep corneas, and this creates a greater hyperopic effect, so we need to target more myopia. For example, in a patient with a K of 53, we may need to target between 2.5 and 3 diopters of myopia in order to have a good outcome. So, I hope these tips have been helpful to you, as they have been to me, and I thank you for your kind attention.
Dr. Beiko is definitely one of my favorite Canadians in ophthalmology. Always happy when he contributes. Next up, we have our medical advisory board member, Dr. Harvey Uy, talking about how we all deserve second chances. Lord knows I need them. But this is about modular and multi-component IOLs. Let's take a look.
Hello, I'm Dr. Harvey Uy from the Peregrine Eye and Laser Institute in Makati City, Philippines, and it's a great pleasure for me to be here to talk about the role of exchangeable intraocular lenses and how we need second chances. These are my financial disclosures. We are currently doing about 22 million cataract surgeries worldwide per year, and this number is expected to rise with the aging population. So it's a good time to be an ophthalmologist. Only about 10% of these surgeries are using premium intraocular lenses, and apart from cost considerations, there's genuine concern among patients over getting bad refractive outcomes or experiencing visual disturbances should they choose to receive these presbyopia correcting or premium intraocular lenses. Over time, we're doing better and better with refractive outcomes, but even with advances in optical biometry and calculation formulas, there's still a significant number of patients who would get refractive surprises with over 1 diopter over the target refraction after surgery. This is even more prevalent among patients who've undergone corneal refractive surgery, and we all know there's a wave of post-corneal refractive surgery patients who are developing cataracts who are coming our way, and by the time they get here, we need a good way of clinching or being spot on with our post-cataract surgery refractive outcomes, or we need a way to fix the problem easily should we be off. Visual disturbances are also the other group of reasons why patients hesitate to get these premium intraocular lenses, and the number of patients who suffer these visual disturbances is not insignificant. And in many cases, we cannot fix them by any other means except intraocular lens exchange. Unfortunately, with intraocular lens exchange, there's a limited time frame using our current model of lenses, and there's some uncertainty with the lens position with current IOLs. Timing is also an issue. If you do it too early, you might do an unnecessary surgery, but if you wait too long to do the IOL exchange, capsular fibrosis may set in, making the procedure extremely difficult. And if you should choose to do a YAG capsulotomy to correct the visual disturbances and it doesn't work, you've made it a bit more difficult to do an IOL exchange later on. This very nice study from the group of Jordi Jamare shows you the indications and outcomes of IOL exchange. And on the left, you can see a growing number of patients are doing IOL exchange because of premium optic intolerance or error of refraction. And the complications both in and out of surgery of IOL exchange are significant. Some of these complications can lead to permanent visual loss or visual impairment such as corneal decompensation, retinal detachment, cystoid macular edema, and glaucoma. So we need an IOL technology that allows us to exchange the optic at any time after the primary procedure so that we can correct premium IOL optic intolerance, visual disturbances, or errors of refraction. And there are two models which are in development. These are the multi-component lens or presbyopia lens and the Harmony Modular intraocular lens. We'll term them both exchangeable IOLs. So the basic concept is there's two components. One component stays in the capsular bag, and this serves as a stable platform for receiving the second component. And because the first component stays in the bag, the position of the second lens is very predictable. So you have an effective lens position. Exchangeable lenses have these applications. So if there's a refractive error, we can calculate what's the correct dioptric power and exchange the optical component to the correct one. If the patient has visual disturbances, then you can remove the multifocal lens and exchange it for a monofocal one. And if the patient got a monofocal lens and later is unhappy that they need reading glasses, then you can change it to a multifocal lens or an extended depth of focus lens. And if the patient later develops retina or nerve disease, you can even change the optic to one with high magnification to help the patients read. The multi-component intraocular lens or presbyopia lens has a base lens that has optic with power and a front lens made of a different acrylic material also with power. So you can combine these two and inject them together, attached together into the capsular bag. So this is a bit easier than injecting them sequentially and attaching them within the capsular bag. And putting this lens in is generally no harder than putting your standard conventional intraocular lenses. This Scheimpflug photo shows you that these two lenses do not come into contact with each other. And because they're made out of a different acrylic material, they will not stick to each other. The front lens is hydrophilic, the base lens is hydrophobic. Okay, and if should you want to do an exchange, this is how you do it. We developed this technique. You inject OVD through the dialing hole to lift up the front optic, grasp the attachment tab with an IOL forceps, and just pull it out through a self-sealing wound, and then you get the new optic. Inject it through the same wound, and these tabs, we call them, you attach them into loops or arches on the base component. So since the base component is still there, you basically would have the same effective lens position as the original primary optic. So this makes for a very predictable refractive outcome. And this was demonstrated by our trial where we exchanged the primary lens 3 months after primary implantation. And we saw that the EOR decreased tremendously after this enhancement or exchange procedure. And the patient's visual acuity also improved significantly with 100% of the eyes getting 20/30 vision or better 3 months after the exchange or enhancement procedure. So you can see on the bar on the left that after the enhancement, the visual acuity greatly improved. And on the right, you can see that the manifest refraction after the exchange procedure also greatly improved. And you can see that we're actually getting better outcomes with this exchange procedure compared to corneal refractive procedure. Endothelial cell loss was minimal and quite acceptable with the exchange or enhancement procedure. Now let's turn our attention to the modular intraocular lens or Harmony lens. This is different from the multi-component lens in that the base component doesn't have any optical element. So it just serves as a receptacle for the optical component. Okay, so you inject this sequentially because the base component is quite thick. So you first inject the base component. You can see that part of it is colored, so you can easily visualize it. And just imagine it to be like a donut, only that there's a groove within that donut, and you will attach the optical component into this groove. Okay, the lens has been designed so that it's very easy to see the groove, or which serves as a landing platform for the optical component. So the leading edge has two ears which attach very easily into the groove. Okay, just use regular instruments to do this. And then the trailing haptic has a tail which also very easily attaches into the groove. And once you combine these two, you can actually still rotate this lens, if it were a toric lens, to the optimal alignment position. So we got very good visual outcomes with the Harmony lens, and there was a small subset of patients that 3 months after the surgery had significant refractive error with a mean value of minus 0.9 diopters. And when we exchanged this to the correct dioptric power and followed these patients up for 3 months, we basically eliminated the error of refraction. So this shows you the power of this technology for correcting error of refraction. Anterior chamber depth was very stable even after the exchange procedure, and PCO rate was very low. So the advantage of the exchangeable intraocular lens concept is that you have a second chance. You have a built-in plan B. If the first lens does well, you get a good outcome and you have low PCO rates. But if you need to change to the correct dioptric power or to a more acceptable optic, then you get the second chance, and there's no fear about delaying the procedure, and there's also generally no fear about doing the exchange procedure, even if you've done YAG capsulotomy. And as a bonus, this lens, I think, has significant potential for treating patients who have unstable refractive error, such as children, growing children, and patients with pathologic myopia with ever-increasing nearsightedness. So you can actually keep changing the optic to catch up to this changing EOR. So before, we were worried about waiting too long to change a traditional lens, but with these exchangeable lenses, we find it actually even easier to exchange the optical component once fibrosis has set in, stabilizing the base component. I think this will be very useful when this wave of post-corneal refractive patients come to our clinics with cataracts. It will give us a second chance and get good refractive outcomes. So there are, of course, other second chance options. These include the light adjustable lens. In this very innovative technology, the lens optic is made out of photosensitive silicone material. And after you put the lens in, you will use a laser beam to change the refractive index of the lens to settle in on the final power. So basically, you set the power of the lens after the lens has been placed inside the eye. And this can be done very accurately. The other second chance option is refractive index shaping. So here you use a femtosecond laser to change the refractive index of a standard intraocular lens, and you can change the power of that lens, and you can even put in multifocal optics theoretically. So this is just a comparison of exchangeable lenses, light adjustable lenses, and refractive index shaping. So the exchangeable lenses have the advantage is that you don't have any special equipment needed. You just buy the lens itself, whereas with the other two, you would have to invest in a laser The exchangeable lens is repeatable. The light adjustable lens, once you lock it in, you won't be able to change the power anymore. Okay, and for the exchangeable lens, you can convert from mono to multifocal and vice versa. There's also routine post-operative care for the light adjustable lenses. You have to wear special UV blocking sunglasses afterwards. Okay, and you can do the exchange procedure anytime, whereas with light adjustable, you have a window with which to do the correction. Refractive index shaping you can also theoretically do anytime after the primary implant. So in summary, premium IOL use is currently limited by concerns over residual error of refraction and visual disturbances. The upcoming exchangeable intraocular lens, I think, will be a very welcome toolkit for refractive cataract surgeons, because this will give you a second chance to correct any errors. There are no time limits for this exchange, so this lessens your stress. It's generally a safe procedure, very short learning curve, similar to putting in a primary intraocular lens. There's a wide range of applications, and also there's no need to invest in any special equipment or capital outlay. So I think the future is ripe for refractive cataract surgery, and exchangeable lenses will definitely play a prominent role. Thank you very much for your kind attention.
Harvey, thanks so much for that great presentation. And next up, we have Dr. Sahil Thakur with the drug compliance conundrum. And this is a case for glaucoma diaries. Let's find out what these diaries are all about.
Okay, thank you so much, Matt. So the topic that I'm going to talk about is the drug compliance conundrum. I am Dr. Sahil Thakur, and I'm currently a clinical research fellow at the Singapore Eye Research Institute in Singapore. I have no financial or commercial interest in the material that is discussed in this presentation. So as we know, the burden of the disease for glaucoma is increasing every day, and the magnitude is going to be in the 100 million range by the year 2040. It's a chronic disease with no cure that is available. There is significant impact on the quality of life of the patients. Despite good IOP control, progression still occurs in about 20 to 25% of the patients. However, what is concerning is the rate of persistence of treatment is generally below 50% at year 1. Previously, in other systemic diseases, some people have tried to address this issue of persistence of therapy by trying out digital diaries. So in these two studies, one for the self-measurement of blood glucose and the other one for long-term metabolic control in diabetics, what they found out was that a lot of subjects actually are very happy and willing to try out digital diaries to improve their compliance. About 23% of them have no errors at all, and around 50% of them have clinically accurate diaries with less than 10% error rate. In the larger study in Germany and Austria, they also showed that those who more frequently monitor and regularly put their blood sugars into a digital diary, they have a better metabolic control. In addition to these, the digital diaries have also been tried in diseases like for physical activity monitoring in people after surgery, for chronic heart failure management, and also in stroke survivors. In ophthalmology, we know in our field, there are rapid advancements that are happening. Currently, we are poised to soon see home-based OCT machines that will be available to the subjects, and they can do their OCT at home, monitor the thickness of their retina, and all these updates will also be given by digital devices. Also, we have the implantable IOL sensors that can be implanted into the eye, and then they have a 24-hour recording of the intraocular pressure. So unfortunately, there is a huge divide between what is happening at the forefront of technology and how most of the population in the world, especially in population dense areas like India and Africa, are actually surviving below below $2 a day. So that is why we also need to kind of find out some low-tech solutions like this one from the UK study, in which they used a physical passport for monitoring the child's glaucoma. So this study is by the Brunsel's group. So what they actually did was they printed out these glaucoma passports in their clinic. So this glaucoma passport has very significant but very simple information. So it describes what the passport is about. It describes the primary care provider. Going on, it has some useful telephone numbers. It has a summary of what has been done to the eye in case any surgery has been done, the medical history of the subject, any family history or any family history of any disease. Then the eye drops that are required to be put, what are the current other medications that the subject may be on, the correct technique to give eye drops, and then some FAQs. So a lot of times in our busy clinics, we don't have time to answer certain questions which are very important for the patient. So having a glaucoma passport like this is a nice way so that the patient has a ready retina and they can always look at it. Then finally, it has an area wherein you can put in your notes. So after this study, what they also did was they added on these teller acuity charts inside this. And in addition to that, they had a small area wherein the child could draw their family just to make it more engaging. And then also these removable cards, which the primary care provider used to show when they used to come to the clinic. So this part is to make the children's glaucoma passport more engaging. Overall, what this did was it increased the efficiency of the clinic. It improved the stakeholder involvement. So the child's engagement in the disease management is also increased, and it is a very quick and simple method for implementation. They included this comment from a mother of a 5-year-old son who said that the passport, it improved the safety, efficiency, communication, and thus the management of the disease. Overall, what this shows is that the web-based diaries or the physical diaries can be an effective tool. So the same group actually went ahead and Dr. David Crabb's group, they devised a web-based diary. So what they did was they explained that the patient, he only remains for about 2 hours in the clinic, whereas about 8,760 hours outside over 1 year period of time. So they devised this website wherein for 8 weeks, 10 primary open glaucoma patients, they could go online and they could put in they could fill in questionnaires about their symptom monitoring, their quality of life, and their personality scores. And then they followed up to see what the impact of this web-based diary was on their glaucoma management. So this is a screenshot of what the digital diary looks like on the website. So it has a brief information about the study. It has key dates in case the patient had a visit planned, it would show up in their calendar. It has a daily study task which can be assigned to the subject, like if the investigator wants a specific questionnaire answered. And then finally, it has a small space for journaling wherein the patient can put in their own thoughts. And overall, when the patient completes their study tasks, it gets highlighted in this area. So the patient kind of knows what has been assigned to them. So it is quite interesting to see how the results, they change based upon the patient's temperament. So I would specifically want you to see these two subjects. So as you can see in subject F2, we see quite significant damage in the visual field. However, the symptom change and the personality scores are quite high and the patient had a happy outlook. Whereas see at this subject, which is M6, even though the damage in the visual field is not that high, but still the scores for the quality of life were quite low. So this shows the effect of emotional stability and how that can lead to the patient interpreting their vision loss in very, very different ways. Overall, I'll show you some examples from the journaling that was put in. So these examples basically show human feelings like frustration, anxiety, the need for social support, the need that why and how patients, they trust their clinicians a lot. And finally, something about evaluation, that most of the times in our clinics, we would directly just see the patient's history and prescribe them the medication. In case it's a stable patient, just repeat the medications and don't take the time to adequately talk to them and find out what their problem is. So this kind of a tool can also kind of address that problem, that the patient can feel that they have adequate time in communicating with their doctor. So overall, we can see that what parameters actually make a good digital diary. So basically, it requires that you record these symptoms, the quality of life metrics, have a personality questionnaire, and you can also judge the mood of the subject. You can record the systemic parameters because these are very important in glaucoma management. Also, the visual field for the severity of the disease. You need to have a drug reminder so that the patient can use the same app or the same digital diary as also a reminder tool. Then it is very important to integrate a next visit reminder so the patient knows when they need to visit you again. And finally, it also needs to include some additional things like some disease information, what to expect from their treatment, because a lot of times people think that vision lost on the visual field, they will see some change over time and that vision will gain. So it is very important to explain that what we are trying to do with glaucoma management is prevent progression. Then frequently asked questions, emergency contact information in case the patient wants to reach out to you, and then integration with other health services like the Apple Health Kit or the Google Fit for monitoring of systemic parameters from their watches or any other internet connected devices. Then, if possible, integrating a contrast sensitivity test or an Ansler grid into the application. And finally, the care provider should have an option wherein they can share the data with a new care provider in case they change their doctor. So this is an example of the Connect Omron app. So this is an application developed for blood pressure monitoring. So you can see the output that it produces has scales wherein it shows what your target blood pressure is and how the blood pressure changes over time. In addition to this, you can also record items like the exercise, lack of exercise, reducing salt, any consultation, alcohol, no alcohol, sleep, lack of sleep. So over time, what happens is that you can actually find out patterns that can affect the disease of the patient. So something like this, if it is done incorporating with a 24-hour IOP monitoring device, would be the ideal way to manage glaucoma. However, we are still quite far away from something like that. Another thing is mindful meditation. So meditation can help a lot as well. And this component can be integrated into the digital diary using the Apple Health Kit. For example, on the Apple Watch, the Breathe app is available, which can help the subject to do mindful meditation. And these things can also be integrated into a digital diary. So in order to see why this topic is important and why we need to develop applications, smartphone-based or web-based diaries, is because over time, the number of people with smartphones has exploded, especially in countries which are developing like India. People would think that smartphones are something that are only for the youth. But again, research shows contrary evidence. Actually, smartphone usage has been increasing in the senior citizens. And it has been shown that especially because of the pandemic, the senior citizens are actually more dependent on their smartphones than the youth in these days. So these are some of the apps that are currently available on different platforms. So one, the initial app is an app that can program drug reminders into the patient schedule. It can also show the doctor's visit, find the contact doctor. The other one is again a similar app in which you can put in your intraocular pressures. These are certain other apps which are examples of information tools for the subject. So what you can see here is that though a large number of applications are available right now, there is no single application that integrates all the relevant features. Moreover, the application should basically be available as a cross-platform application. So that means that the person should be able to use it either as a web-based platform or as an Android device or on an iOS device, so that there is flexibility and ease of access. Then data privacy and security are some things that need to be addressed and looked into right from the initiation of the application. And finally, awareness and trust in our patient's ability is vital in case we want them to use the technology for collaborative care. So that is very important to understand, that we need to trust our patients and believe that yes, they are equally invested in taking charge of their care. And herein I rest my case, and I think that digital diaries, especially for glaucoma care, would become integrated into clinical practice in the future. Thank you.
All right. Thank you, Dr. Sahil, for that very informative lecture. I certainly like your cartoon at the end. So
Thank you.
we'd like to encourage the audience to post their questions using the Q&A button on the right lowermost portion of the screen. So maybe I'd like to start off by asking Dr. Sahil. So in the model that you envision, does the practice help the patients program the dosing schedule as well as other elements into the app, or are the patients the one who do it themselves?
Yeah, so currently, I think a very good thing is that we have QR codes, and QR codes can integrate a lot of information very quickly. So in the ideal scenario, what would happen is that the patient would walk in, complete their consultation, and you would do your prescription normally. Then once the prescription goes into the EMR, it will be generated as a QR code for the patient to scan using their app. So they scan that QR code and everything gets automatically integrated into the application.
Okay. And in a subsequent visit, is there any way also to quickly download the information from the patient's app?
Yeah, so this is where the data privacy part comes in. So it's very easy to share PDF printouts, like the example I showed from the Omron Connect app. But the problem is what it would give you is a large graph. What we would actually need are parametrics, or like something like what the OCT gives us, like a checklist score. So a green, yellow, and a red light, depending that yes, the patient has been following the schedule, their medications were at the right time. So something like a compliance score. So you just know that, and that's enough. Otherwise, giving out raw data would also be possible, but interpreting it in a small consultation would be very difficult.
Okay. And do you also incorporate the OCT findings, like the nerve fiber layer, into the app, or do you think that that's not essential?
I think because there is a large difference between how we clinicians think of managing glaucoma and what is important for the patient. For the patient, a lot of times the OCT RNFL value, a change from 90 to 80 would not matter. But yes, over time, if the quality of life scores, they fall significantly, and you see that the score has fallen from like 10 to 5, that is a more significant parameter to be seen. So I feel OCT, yes, it can be integrated very nicely into the EMR to see trends over time. But for a patient app, things like whether their compliance has been good enough or not, whether the quality of life scores have fallen or not, whether they are having severe dry eye symptoms from their glaucoma drops or not. Smaller things like these are more relevant for the patient.
All right, thank you. Very nice, very nice system. I don't know if Dr. Do you know if Dr. Sheetal is online? Dr. Sheetal?
I don't think ma'am is here.
Okay. That's okay.
Yeah, I have a question for you, Dr. Harvey. So have you kind of seen that? So in our setup, what happens is anyone who has glaucoma straight away, or even someone who has a diabetic retinopathy, straight away we kind of tell them not to go in for premium IOLs. What has been your experience? Do you think for early glaucoma, early NTG cases, or early diabetics with well-controlled diabetes and only having like early non-proliferative changes, do you think premium IOLs, especially the ones in which you have the changeable optic, I am very interested in that one. Do you think those can be implanted in those subjects as well?
Yes, so we do implant premium IOLs in patients with, example, early diabetes, early retinal disease, RK patients, for example, and early glaucoma patients. But we don't have a crystal ball to see how these patients will do 5 years later, 10 years later, 20 years later. And that's where having that exchangeable lens will give you that second chance to change the optic years later if the premium IOL starts to not fit the patient's condition. And particularly for patients with macular degeneration, there are lenses that are high magnification. So we have used this successfully in patients. So should their AMD get worse, for example, in the future, we could change that premium IOL now into a high magnification lens to help them read. And I'm sure there may be other glaucoma optics that may be developed, like maybe wide angle
Prisms,
fisheye
yeah,
optics.
prisms or something like that.
Yes, to give you a better vision, and you can put them in if the patients are happy. That's good. If they're not happy, then you can switch them back to their original monofocal lens, for example. So I think it's a brave new world for this type of technology, and it'll give us clinicians a lot of options.
Yeah, yeah. I think the design is especially very innovative, that it has that spoke in one area and the other area has that area which you can hold with your forceps. Have you ever felt, has it like slipped on, or is it or is it uh, uh, is it like easily graspable?
Yes, it's easily graspable. We just use standard IOL forceps to grasp it.
Okay, okay. So it doesn't require a specific equipment or a specific forceps to hold it.
No, no, we are part of the R&D, and we wanted to make sure that simple instruments that you have in your operating room can be used already.
I think that's important when you have a new innovation, to still keep it as simple as possible.
So I think we don't seem to have any other questions. Anyway, you can forward the questions to the individual speakers. They left their emails at the end of their presentations, and we wish everybody an advanced happy Father's Day for tomorrow. And thank everybody for listening. Any last words, Dr. Sahil?
I think this is probably the future for the next, at least for the few years. We are just going to have virtual conferences.
Okay. All right. It's more relaxing and less carbon into the atmosphere.
Yes.
All right. Very nice meeting you, and thank you to everyone for participating. Have a good weekend.
Thank you. Thank you so much.
Bye-bye.